Hi, good afternoon, everyone. Welcome to the community engagement session. My name is Nuran Fakir. I'm an EDCTP project officer based at the EDCTP office in Cape Town. So, shall we get started and welcome our first speaker to the podium, Dr. Anis from France. Just a few housekeeping rules. We also have some online participants, so we welcome them. And please do pose any of your questions in the Q&A chat. Each presenter has been allocated about 12 minutes to present, and we'll have some time for questions after each presentation. Thank you so much.
Thank you. Good afternoon. So, on behalf of my colleagues of the PROMIS EPI Social Science Sub-Study Group, I'm going to present you today the facilitators and barriers to infant HIV postnatal prophylaxis, a qualitative sub-study of the PROMIS EPI trial in Lusaka, in Zambia. So, infant postnatal prophylaxis is one of the two tools with maternal ARV to prevent HIV transmission through breastfeeding. Oh, yeah, nothing I can do. So maybe I can continue on. So the type of drugs used as prophylaxis depends on national guidelines. In Zambia, the national guidelines recommend a 3-drug prophylaxis, which is initiated at birth, and which is composed of dispersible combined tablet of zidovudine and lamivudine given twice a day, and an oral suspension of nevirapine given once daily. In PROMIS EPI trial, the high-risk infants switched from the 3-drug prophylaxis given at birth to the lamivudine oral solution at 6 weeks of age, given twice a day, and continued until 12 months or the end of breastfeeding, whichever came first. And the objective of our sub-study was to explore the barriers and facilitators to the extended use of lamivudine as prophylaxis. We carried out individual interviews and focus group of discussion based on a semi-structured guide with the PROMIS EPI participant, so the mothers who had received the 2 types of prophylaxis, the one given by the national program and the lamivudine given within PROMIS EPI trial for their children, the PROMIS EPI nurses and clinical officers, and the healthcare providers at the facilities where PROMIS EPI was carried out. We selected the interviewees based on a purposive sampling approach, and the infants were between 6 and 18 months old at the time of the interview. The sessions were audio recorded, the verbatim were transcribed and translated from local language into English when necessary. We designed an initial code book with a priori codes, which was then adapted on the basis of emerging themes. And finally, we performed a descriptive thematic analysis. We included in our analysis 17 individual interviews and 8 focus group of discussion. So in total, we had in our analysis 33 PROMIS EPI participants, 8 PROMIS EPI staff, and 9 healthcare providers, including nurses, counselors, lab technicians, and the pharmacists. 3 main themes emerged from our analysis. The first one is a comparison of facilitators and barriers to adherence for the 2 types of prophylaxis. And the results are presented in a graph. The first subtheme was the number of drugs. So if you remember well, the national guidelines in Zambia recommend a 3-drug prophylaxis in 2 different formulations, which was seen by the interviewees as a barrier to adherence compared to the single drug used as prophylaxis in PROMIS EPI with lamivudine. The second subtheme is a type of formulation, and the dispersible tablet used by the national guidelines was seen as a barrier to adherence as well, due to the difficulty to understand how to proceed, especially in case of illiteracy, and the time-consuming process, which was notably an issue in case of the mother did not disclose their status, HIV status, with their partners. When we talk about time-consuming, it means in case of no clean water available, the water has to be boiled by the mother and wait to cool, and then the dissolving process itself took time. And in case of contamination by a bee, for example, or dust, the process needed to be repeated. On the other side, on PROMIS-EPI study, the ready-to-use formulation was considered as a facilitator by interviewee, despite possible spillage. Another subtheme was the secondary effects, with more adverse effects reported with the three-drug prophylaxis by the interviewees than with lamivudine. And the interviewees highlighted in particular the bitter taste of the zidovudine, which led of the infant spitting up and had an impact on children cooperation, compared to lamivudine and the sweet taste of lamivudine, which had a positive impact on children cooperation. An increased appetite was also reported, which can be seen as a facilitator or a barrier. Another subtheme was the dosing device. In PROMIS-EPI, we provided the participant with syringes, which were not easy to use at first, but then were considered as facilitator because it allowed precise dosage and easier administration, notably when the baby was sleeping. And finally, the novelty of the drug in PROMIS-EPI was seen as a barrier because of the suspicion it could raise in the community. So after the comparison of the two types of prophylaxis, the second theme is the extended use of lamivudine as prophylaxis, with two subthemes. The first one is barriers to long-term lamivudine adherence. And you can see on this table the two main barriers reported by the interviewees, as well as the strategies put in place by the PROMIS-EPI participant and the PROMIS-EPI staff to overcome them. So to deal with forgetfulness, the PROMIS-EPI staff recommended the mothers to determine a specific time on the day to give prophylaxis to their children and to take their own ARV. To deal with non-disclosure and stigma, some mothers shared with us the tricks they used to hide the drug involved. As in the quote on the right, a mother said, "I had challenges giving the medicine at the beginning due to lack of disclosure. I got a paracetamol bottle and put in lamivudine." The second subtheme is a relation to breastfeeding, with adherence to lamivudine having an impact on breastfeeding behavior, with two different quotes reported here. One is, for me, when I forget, it means I will not breastfeed my child for fear of putting my child at risk. And another one, what made me to breastfeed my child up to 1 year and 1 month was because of the medication that I was getting from PROMIS-EPI. The last theme is the adherence to prolonged lamivudine use versus maternal adherence to their own ART. And several mothers reporting to be more adherent to the infant prophylaxis than for their own ARVs. As on this quote, I didn't have challenges when giving my child medication, but mine, that's where I had a challenge because I found it hard to accept. And this mother referred to the adverse events that she experienced with her ARVs. So the desire to protect their child gave the mothers the courage to face the challenges of giving lamivudine during an extended period. They didn't want their infant to be infected due to their negligence. And the POMISI PI staff reported that for some mothers, infant prophylaxis was a more direct and easier way to protect their child than indirectly by taking their own IRVs. As a conclusion, regarding the type of infant prophylaxis, the main barriers to adherence with the 3-drug prophylaxis was due to the zidovudine, lamivudine formulation, so the dispersible tablet, and this was due to this was challenging mainly in case of non-disclosure and may have contributed to inadequate dosing. Lamivudine was preferred in our study by the interviewees due to the ready-to-use formulation and a better palatability due to the sweet taste. And the extended use of lamivudine was generally well accepted, and mothers find solution strategies to overcome the challenge of long-term lamivudine use. So finally, the choice of tools to prevent HIV transmission via breastfeeding, I mean the type of prophylaxis regimen and extended prophylaxis in non-adherent mothers, may be one of the keys to reducing the burden of pediatric transmission in low and middle income countries. I would like to thank all interviewees, my colleagues, the POMISI PI Social Science Sub-Study Group, and the funders. Thank you very much.
Thank you, Dr. Anis, for your excellent use of time. If there are any questions, please approach one of the microphones.
It was clear enough. Yeah.
Can you tell us what were some of the challenges in implementing the study?
Yes, maybe I can raise the limitation of the study that were not presented here due to the time constraints. The two main limitations were, first, the interviewees were the participants that were not lost to follow up during the main study. So it means the mothers that were the more adherent to the POMISI PI trial, and so we could not interview the mothers that were lost to follow up, and that for them the study was maybe not much appreciated as the ones that were followed up to the end. And the second limitation is that the interview were performed by the POMISI PI staff. It means by the staff who followed and cared of the POMISI PI participant during the main study. This was a choice because they built a relationship between the staff and the participants, and it was easier for the mothers to share their experience with the staff they knew. But it could have induced a desirability bias using this strategy.
Okay. Thank you so much.
Thank you.
May we call on our next presenter to take the podium, please? Dr. Esther Burigiya from the Makerere University School of Public Health. Thank you.
Thank you. Good afternoon to you all. Yes, I want to thank EDCTP for the opportunity to be here to present the study findings, but also most important for funding this study. The title is Stakeholders' Perspectives and Willingness on Use of SMS Reminders and Mobile Money Incentives to Reduce Loss to Follow-Up Among Presumptive TB Patients in Uganda. That's my name, Esther Boreje, as I've been introduced, and I'm an associate professor at the School of Public Health. So, loss to follow-up of presumptive TB patients is a major challenge towards realization of the NTB strategy, a very ambitious strategy. I'll not go into the details of, reducing 95% death, reducing incidence by 90%, and 0 families facing catastrophic expenditure due to TB. And presumptive TB patients, these are patients who present with symptoms of TB, that is cough, fever, weight loss, and night sweats. So ideally, when these patients present, you should evaluate them for TB, and if they are found to have TB, then they are started on treatment. But when you lose them, when they lose their loss to follow up, then they continue to transmit TB in the community, and then they're more likely to die. And so that's why it's linked to the failure to reduce to be able to meet the NTB strategy. So innovative interventions are really critically needed to reduce this loss to follow-up of presumptive TB patients, mainly around the area of improving provider communication, as well as addressing economic barriers. TB is really intertwined with poverty. TB and poverty are so closely intertwined. And short message services, or SMS, and mobile money incentives have shown promise in improving health outcomes, especially in improving uptake of immunization, and also adherence to TB treatment, and ART. And given the high percentage of mobile phone possession in even low and middle income countries, including poor people, and this gives a great opportunity to use mobile phone interventions to improve health outcomes. However, this had not been tried out to see how this can improve linkage to care for presumptive TB patients in the low-income countries, especially Uganda. So this was a behavior trial, which was trying to look at the effect of SMS reminders and mobile money incentives to improve linkage of presumptive patients. And so these findings I'm presenting on the second objective, where we're supposed to adapt and refine the SMS reminders and mobile money incentives to improve linkage of presumptive TB patients. So that was our proposed intervention. We set out to use SMS reminders, but also, and this is to remind the patients who come to the facility. And the challenge here is that when a presumptive patient is identified, because they are not given results the same day, for them to return, that improves. When they are not given same-day results, they are more likely to be lost to follow-up. So the SMS reminders are to remind them to come back, but also the mobile incentives were meant to provide transport, because these are usually poor patients, and so they can have a challenge to come back. But as we designed this, we felt that we should contextualize these interventions, the mobile money and the SMS, to bring in ownership of this intervention and be able to know that this actually works. So as part of the methodology that I've already mentioned, the adaptation of this intervention involved conductive qualitative interviews with stakeholders to solicit their views regarding this intervention that we had proposed, which was SMS and mobile money. So we did conduct 20 key informant interviews with health workers, in charge of units, OPD, ART. This is where TB patients are picked. 25 in-depth interviews of presumptive patients to understand their experience during that presumptive period, and 8 focus group discussions with TB patients who had already been, gone through this. This was in 4 health facilities. These were audio recorded and analyzed using Atlas TI version 12. These are the results. First of all, like I'd said, we set out to use SMS and mobile money, and so these were viewed as important interventions. So there was a unanimous agreement that transport facilitation, that is the mobile money, that was very big, it was beneficial and would motivate patients to come back to the facility. For example, the court, yes, that money will encourage them to go to the hospital. However, almost all respondents viewed SMS as not a good way to remind patients to come back to the facility. Remember, I'd say that we used SMS and phone call and mobile money. We didn't have a phone call in this. So the majority, they went ahead to suggest that he would prefer a phone call compared to an SMS. Though a few just preferred SMS, and they said the reason for preferring an SMS was that if you're not with your phone, you can be able to come and find this message. And so let me go to give the reasons why messages or SMS were not preferred. First of all, they felt that they would lead to involuntary disclosure. For example, this quote, with messages, I do not think it will work like calling. Because you can be with a friend and he asks you to use your phone. So what if a message comes when the phone is with your friend, whom you've not disclosed to? And what if the person reads the message? So it was felt that this can lead to inadvertent disclosure. And so they didn't like the message for that. The other was some people can't read. So I did not go to school. This is a quote from an FGD of females. I did not go to school. If you send a message, I'll not read it. I'll just look at it and keep my phone. The other issue was that you're not sure that this message has been read. So a message is easy to send, but you're not sure whether the person you've sent it to have read it. The other bit was lack of details and no feedback. When I send a message, it can be scary. Some felt it can be scary because it doesn't have that detail. It cannot explain to me everything that you would have explained to me over the phone or physically, because you can cancel me, which is not the case with a message. So there's even a bit of canceling when you're doing it over the phone, which is a message would not happen. There was also an issue of fatigue. They were talking of the service providers sending a lot of messages, so they tend to delete them, so they feel that even a useful message from the health facility will be deleted in the process. Then phone calls. Why did they prefer the phone calls? Yes, the other side of the coin, they felt they were confidential. Phone calls are very confidential. Phone calls can be effective, like this quote. I believe that when you call me, the person next to me does not know your phone and would not understand the reason for the call. For example, if you can inform me that I'll be needed at the hospital on the specific day, this is different from a message where someone can stumble upon your phone and read the messages. Then also there was an issue of sign of care that I like it because it's important to hear from a health worker. And then the next quote shows that when the health worker calls you, then it shows that the health worker cares. And that relationship between a health worker and patient is really important to retain them in care. There was an issue of also that the phone is really detailed and gives you instant feedback. Just allow me to go through this quote also, that the phone is very good because I might have had a bad night, and by the time you call, I really needed to talk to you, meaning talking to the health worker, but I did not have airtime. It means you will be able to pass on the message that you wanted to give me, and I will also be able to share with you my situation. Then also it's not easy to ignore. It's ringing. And then the issue about the mobile money, they agreed that they needed it, but there was varied way of how this money, this incentive should come in. So we had thought of sending mobile money to their phones before they come to the facility, and then they said, no, we prefer cash than mobile money. And the reason here was that they don't have, though we had assumed that even poor people have phones, but they said that some patients don't have phones. And usually at the facility in our setting, you leave a phone for the next of kin. But most of them, so they didn't have their own phones. They would leave phones for the next of kin. And they felt that the next of kin, once they received the money, they would not pass it on to the patient. Then there was an issue of the mobile money withdrawal charges that they felt would reduce on the amount that they will receive. And then this other important one, they said that you rather reimburse the patient once they've received a service than sending the money before they come, because they felt that the money would be diverted for other purposes. For example, this quote, money will become partial instead of transport. Or this other one, I'll use myself as an example. When you send me money, like 10,000, this is about $3 US, I might use the money for to buy alcohol. So conclusion, so there was limited preference for SMS reminders with a preference for phone calls. And really what we did from this, we went ahead and made an amendment. We had to add phone calls because this is what the stakeholders were telling us that works. So we had to add another component, another arm of phone calls, which we didn't have from the beginning. Then phone calls were believed to show care to the health, from the health workers to the patient. And as we embrace M-Health intervention, I think the human interaction between patient and health worker needs to be maintained. Then there was a fee of mobile money incentives that sent to the patient prior to coming to the facility, but that it might be diverted for other purposes. And then, of course, lack of phones limits the delivery of phone-based interventions. So once again, I want to thank EDCP for funding this study, and the participants of this study, and the mileage study team, and all of you here. Thank you for listening.
Thanks so much for that presentation, and perhaps we can take some burning questions. Please, can you use the microphone on the side?
Thank you. I only caught the second half of your talk, which was fascinating. I just wanted to check, when you were talking about giving people money, because in my work we do that, we give teenagers money to do activities before the activity themselves. I was just wondering, was that your healthcare workers or your researchers that were saying that they had concerns that people would spend that money on other things, or was that the feedback you got from the people that were given the money, or was that evidence of that actually happened? Does that make sense? Sorry.
I think I got your question, so thank you for that question. So this came, like our respondents were health workers and patients, but more strong views about reimbursement was coming from the patients themselves. They really said that. They were, I don't know the quotes that I used here, but it also came, like this is an FGD. These FGDs were conducted among TB patients. So they said the money for transport would be used for posho, will turn into posho. So it really came from the patients themselves.
Sorry, I'm really curious about this because that's fascinating. Are they saying that they themselves would do that, or they wouldn't do that themselves, but they think that other people would do that?
No, they believe that once one receives that money, they said there is poverty. Once you send us that money, we will not come. We will divert it to other purposes. So they felt if it's meant for this, give it to me when I've accepted that I've come to the clinic, and so it's like a refund of the transport I've used.
That's because our experience, which is a very small group, is the opposite. Actually, we do give the money up front, but they commit to the work. So it's just really fascinated. Sorry.
So we really had to change because we were supposed, this is the other amendment we had to make in our protocol, because we were supposed to send them money before. But given this feedback, it's when they access the facility. In fact, we give them a voucher when we enroll them to show it is like a promise of money. It's then when they come to the facility, that's when we refund the money. Came all from them. Thank you.
So let's take one. Okay, we've got two questions. Let's make them brief so we can move on to the next speaker.
All right, thank you very much. My name is Maxwell from Ghana. My first question, you are talking about money, but you didn't say how much. Sometimes the amount also determines whether they will use it, or so it's not clear about the money. And your interest is presumptive care. I'm just wondering why you are using presumptive patients, because it's a health system issue. If you know your test, it takes time, why don't you improve? So that the person has to wait for you to give him money when you can just give the results. You have to pay incentives. So why that? And also, if the money is big, is it sustainable? Is it sustainable? So you need to think about sustainability issue. If not that, people will intentionally go and get TB because they know they'll get money. So you need to think about that too.
Thank you for those good questions. One, yes, ideally we should be doing these things, giving results the same day, but that doesn't happen. In reality, in our place, it's not happening. You're going to find people who are going to tell you, by the part of this study was looking at the barriers and facilitators completing diagnosis in time. And some of these was delayed receiving results that, when I picked as a presumptive, it takes like a week or 3 days to receive my results. So these are challenges within the system. We, as a country, we're trying to move forward to see how we can be able to provide same-day results, but when the workload is high or something, some challenges, you are not able to get that. The other issue was the money. Yes, I did not give more details here. We went ahead and asked the stakeholders, what do they think? We didn't have that much money, but what would make sense as in terms of how much money they would be able to support them. So people were like, it depends, you should give depending on where the person is coming from. Because people come from varying, the distances vary, so it should be commiserating to how far they are coming from, and so, but it should be, equivalent to that. Though some felt that if you can also add and they be able to take a meal while at the clinic waiting in the line, that would help. But we didn't have much money, and we're giving them around 10,000, which is about $3 US, and we are yet to see as we end this how helpful this was, or if it is required to get better. But this is still about WHO going ahead, the drive or the recommendation to address these economic barriers. These patients are poor. So if you support them, then you are able to, I agree it can be a challenge sustaining this, but I think there's been a recommendation for addressing these economic barriers, especially faced by TB patients, to be able to access these services. And maybe just to add, like I didn't give details, there was a systematic review which showed that about 40% of presumptive patients were lost to follow-up. So if you lose that proportion, and these are the people who could be having TB, so transmission continues, and so it's really an important area, and previously it has been on TB patients that have been supported. They get they were supplied food, they are given money, but then the presumptives where these cases come from has been ignored, and so there's moved to also put emphasis on around that presumptive period. Thank you.
All right, let's take the last question.
Okay, thank you very much. I think your research actually addressed a very important topic, right? It's like turnaround time for TB, for getting results, as well as initiating the patients on treatment. And loss to follow-up is a very, very important problem. So I'm particularly delighted to see that you guys are coming out with initiatives that can actually improve on this. So the first question I have for you is it possible for you to do some sort of economic modeling to actually establish the real cost that a country that wants to go this route can take? Because I think countries can actually decide to integrate that into their global fund applications and can actually match the funding, because this is a really significant problem. Mm-hmm. Thank you. And secondly, I also wanted to find out the patient type. Were they uniquely adults, or you also had pediatric cases?
Thank you. I think the one of doing an economic valuation of this intervention, that's a good point. Maybe doing it in it wasn't within the scope of this study, but that's a good idea. You need to see how much do you gain by giving that, because many people, like the previous person mentioned, that giving out this money is not sustainable. But if you make a case why it's important, you're saving so many lives and then probably it will be a worth investment. The issue of, the second question was, your other question? The patient population, adults or peds? Oh, no, we are only dealing with adults. Because when you bring in the children, then it's complex, the dynamics. You need, as a child, you need a parent or someone, a caretaker to take you. So here we considered 18 and above, the ones that were enrolling in the trial. But even these interviews, it had to be those above 18 years. That's what I can say. But in the trial, we are still using 18 and above. And just to share a bit of the experience from the trial, though we thought that phone possession
Dr.
was high.
Esther, could I just cut you? Let's get through the other presentations.
Okay.
And then we'll come back to a discussion. I don't want any of the other presenters not to get a chance.
Thank you very much. Our next presenter is Professor Savannah from Mozambique. Thank you.
So thank you. I'm Esperança Seven from Mozambique, as was said. I'm presenting on behalf of my colleagues that they couldn't be here. Some of them I think are here. But what I'm going to present is working toward better guidance for studies that involve African health volunteers in the context of the Vor Ethic Initiative. This is the content of my presentation. Thousands of people around the world agreed to take part in clinical trial as health volunteers to test new treatment, such vaccines, drugs, or medicinal devices, also to participate in human behavior or observational social science studies. Health volunteers may be vulnerable to financial pressure if their socioeconomic level makes them more lucrative, make their participation in the study more lucrative than other economic activity. Health volunteers can clandestinely participate in several studies, and that increases the risk of harm and also compromise the scientific validity of the studies. Ethical guidelines for biomedical research lack specific guidance for studies targeting health volunteers. The objective of this study, the study is part of the context of the ethic committees of the French National Institute for Health and Medical Research in CERN that convene an initiative to propose the elaboration of a good practice to protect health volunteers in research, and we call this initiative Vor Ethics. We use this definition of health volunteers as health people who do not have a non-medical condition related to the purpose of the study that we are implementing. We convene regional online workshops in Africa, Latin America, and North America, in Europe and Asia. Before the workshop, we send a pre-workshop questionnaire that the participant can respond on it. And then during the online discussions, we took notes to summarize the topics that we're discussing using a thematic approach. Then we had feedback from all regional meetings and plan for developing the international guideline. And this was in Brussels in April 2023. And we had the participation of stakeholders that included regulatory authorities, manufacturers, research institutions and funders, ETCs, and health volunteers. The results that I'm presenting here are from the regional online workshop that took place in Africa, for the group that work in Africa. In this chart, I'm showing that we had 14 African countries participating in our workshop, 7 from outside Africa, and the participants were 78, 3 of them were health volunteers. And from these, 39 complete the questionnaire. We organized the results as teams, as I said before, and the first team is African examples of possible exploitation. We found in the discussions that lack of community engagement include risk communication, issues regarding the informed consent, like complete absence of informed consent or insufficient information in the informed consent, or use vulnerable groups to consent, for example, consenting during labor. And also we had discussions around specific concern about using food as an incentive in poor population, because it's common that people offer during the studies food and then people participate in the studies. We also discussed lack of participant awareness of injuries compensation process, for example, activating the insurance plan that was in the trials. Specific to genetic research, we also discussed the lack of robust mechanism to privacy and lack of feedback on results, even when we include in our consent form that we will give back the results, sometimes we don't do it. And lack of guidance on compensation for secondary use of the data. The other theme that we have was the examples of possible solutions. For this, I'm starting with education and dialogues, what we have. Invest in education in biomedical research and bioethics to strengthen competence to prevent or mitigate risk. Here we have discussed to ensure research protocol that align with ethical standards, innovative and collaborative learning initiatives tailored to key audience, and constant dialogue between stakeholders to strengthen understanding of the research process, roles within an interconnected framework. From education, we also discussed the need to involve research team, higher education institution, and also involve potential participants of studies. And there were examples of the type of trainings that we can do and also the techniques that we can use to train, like use videos that show the reality of the complex studies, for example, the first in human studies. The other topic that we have in possible solution was the role of health authorities and ethics committees, the need for acts of legislation, particularly for the national health research ethics, the capacity for strong, competent, and independent ethics committees with effective continuing oversight, and the robust, comprehensive ethical review to the protocols and assessment of the information, particularly information that we give in the informed consent. We also discussed the need for field visits and follow-up and monitoring the process, perhaps the briefing the health volunteers to make sure that they understood the study that they are participating. It's true that the literature presents that most of ethics committee are not trained on, particularly in complex studies that involves health volunteers. The other theme that we have in possible solution was the community engagement and informed consent. Comprehensive community partnered engagement to empower communities about their right in research, making sure that they can ask questions. They can say, no, I don't want to participate. This should be a message that people should receive. Establish platforms to which elected community representatives have input, not only in the implementation phase, but involve them in the developing design and also complementing the research questions. Have clarity on writing informed consent, particularly if it's needed, use local language to emphasize the information that the volunteers has to receive and that the study is volunteer. Guidance for compensation health volunteers, because we saw from the discussions that there is no guidance. Each country, its institutions use different ways to compensate the participants without taking in account the risk of inducement. It's in the informed consent, it's needed to ask questions, to have the opportunity to ask questions, and the questions should be answered, to have clarity in the message that we pass, and gain the trust between the researchers and the participants. In conclusion, this important initiative has established momentum for closing gaps in how studies enrolling health volunteers are conducted ethically and equitable. Further discussions with the colleagues from the other regions involved the vote ethics should enrich the approach towards sound good practice. For more information on this initiative, I recommend you to read this article that is published. I want to acknowledge all the participants of these seminars and the respondents to our questionnaires and all the team that is involved in this initiative. And these are the sponsors that I'm also recognizing here. Thank you for your attention.
Thanks so much, Professor Savine. Do we have any questions? Feel free to make your way to one of the microphones. If there's anyone else, please make your way to a microphone.
Thank you very much for this excellent initiative. One of the solutions that you prefer is a clearly written informed consent in local languages. But there are some countries in Africa where the local language exists only in oral forms, and there's no standardized way of writing them. So what do you suggest as a way out or strategies to overcome that challenge? Thank you.
No, this is a challenge also in my contest because some languages are, some are already written, but people can't write and read. But in that context, it's difficult to us to translate because people will not manage to read. But there are people that can read. Instead of having oral explanation of what the process is, having and written in the local language and find someone who can read this consent in the local language. It's better than have someone who will try to translate while it's talking with the participant.
I agree with you completely because that will not be a standardized way of giving the information. Mm-hmm. And in that way, the information given or the quality of information given will depend on the communication skills of the person giving the information. I faced this kind of challenge in many of the countries where I've worked. So where the local languages exist only in oral form, and the local languages are not taught formally in schools. They do not have alphabet like other local languages. And I find that it's not peculiar to one country. There are several countries that are having these challenges. And clinical trials are taking place there. So I think we need to look inward and find a way of addressing that challenge.
Yes,
Thank
I
you.
agree with you. It's something that was raised also in the discussions.
There's a question at the back.
I'm Ham from Muhimbiri University. So you say that some of the issues which, some of the way which can be classified as a kind of, is it DALE, a kind of like incentivization through having providing food to people who are not in access of food. And so maybe you can clarify more what are the criteria now to say that this approach towards signing the informed consent followed the GCP, where someone, because at this interface between the researcher and the participant, it is sometimes, I think it's very difficult. Maybe you can provide a well-clarified criteria to say that if you do this and this and this, then you have followed the GCP. Thank you.
Thank you. That wasn't the objective of this study. We were only collecting the perception of the participants of these discussions. And the point that was raised by the participant was this one regarding giving food to people, and then people accept to participate because they need their own need of this food. But we didn't discuss on the solutions, on what exactly is the appropriate way to us to assess the participants. And this is what we are working in this whole initiative, to identify the problems. That is the first step that we did. The problems are here, were raised. And then we are then analyzing them and see what teams need attention and can be included in an universal guideline to protect health volunteers. I'm not going to in detail in what we have discussing there, but we are trying to identify teams that we think that are relevant to go to this guideline that will guide all of us on how to protect health volunteers. And this initiative, it's working on this. We had several discussions. There are teams that are already identified, that, and we are working with UNESCO, WHO, and other institutions that will be interested, and the European Union Commission is the most interested on this. And we are working together and see where to place this recommendation and how this recommendation will be appropriate to all the health volunteers that will be included in the studies.
Okay, one more question.
Thank you for this wonderful presentation. One of my big challenges for conduct research is that in most places that I do research, there's another kind of projects and interventions that approach communities. And when they approach communities, they give like food and other stuffs. And, when I go there, I want to also engage the community and talk to them about the issues. And they claim about these things like food. One of the solutions that you point here is the education and community engagement. And yeah, I wanted to know if you were able to discuss the best approach for conducting this, particularly education, so that community perceive that this is research and the another thing is another, yeah, intervention or something like that.
We as I said before, we discuss the themes that the people were raising. This is a problem, and that we summarize these themes that we have in the, there were online workshops and people raise questions, and then we also systematize the answers that we get from the questionnaire. But we didn't discuss the right solution. We put together the suggestions that were coming from these discussions, the discussions and the questionnaire. It's what we are presenting here. But then we have the stakeholders meeting where some teams were discussed and trying to be more focused on how can we go to a guidance and what teams can come in this guidance. And some topics that we're discussing were related to informed consent, how to protect from harm and risk. There are topics that they have interest on having a written guideline that we can discuss and agree on. This will be a process, a long process, that people will come with some, how can I say, suggestions on what will come in the guidance. But this is the starting point where we got people raising the topics that need to be addressed.
Thank you so much. I think let's give her a round of applause.
Thank you.
Our fourth speaker is Dr. Torres from Manisa in Mozambique. Thank you.
Thank you. Good afternoon. It's my honor to be here and present these results of this study and on behalf of all authors for the Multiply project. The study is entitled Acceptability of Future Introduction of Intermittent Preventive Treatment for Malaria in Infants in Masinga District, Southern Mozambique. So Mozambique, my beautiful country, is amongst the top 5 countries where malaria is highly endemic, affecting mostly pregnant women and children. WHO, back in 2010, recommended intermittent preventive treatment in children under the 2 years of age, and last year recommended perennial malaria chemoprevention for the control of malaria in children living in areas with moderate to high transmission, such as Masinga district in southern Mozambique. So Multiply project is a multi-country 40 months implementation research project going on in Mozambique, Sierra Leone, and Togo. It intends to administer full therapeutic course of 4 to 6 doses of sulfadoxine pyrimethamine, SP, delivered through vaccination programs at defined intervals starting at 3 months of age. So this study aimed at evaluating the acceptability and operational feasibility of PMC prior implementation and generate knowledge to inform 1, the implementation of PMC in Masinga district, including human, logistical, and material resources needed, and 2, key message for community mobilization and engagement. So we had 3 main questions. First one, what are the overall malaria prevention and vaccination perceptions? Second one, which aspects of context and community mobilization were important to consider prior to the PMC implementation? And last, what are the knowledge, attitudes, and practice of healthcare workers in relation to malaria prevention? Masinga district is in southern Mozambique, as I said before, and this map on my left is maybe your left is Mozambique, the map of Mozambique, where we present malaria prevalence in children by province. So Inhambane province is located here in the southern part, which 35% of malaria prevalence in children. And Masinga is located in this province. The other image is the map of Masinga on your right, my right, your right, I think. It's map of Masinga, and the red dots represent the health facilities where we collected either qualitative or quantitative data. Masinga is the largest rural district in Inhambane province, and the healthcare services are provided at the primary level by 15 healthcare centers and 1 district hospital. We conducted a cross-sectional implementation research study from May to July 2022, and we had 2 components, the qualitative component and the quantitative component. For the qualitative component, we had semi-structured interviews. We recorded, transcribed, and translated. Some interviews were translated from local language to Portuguese, then from Portuguese to English, to allow the consortium and the project team to access the data. We also performed quality data control, and teams were iteratively and collaboratively generated. For the quantitative component, we 56 CAP questionnaires were self-administrated with healthcare workers, involving those working only with children under 5 years. And in the context of Masinga, we involved medicine technician, healthcare workers, and maternal and child nurses, healthcare workers. In 38 for maternal and child nurses, and 18 for medicine technicians. We also had contest observations in 4 health facilities, and a direct administered contest questionnaire with 4 health facilities in charge. in charge. For the qualitative, as I said, it was semi-structured interviews only, and the participants were healthcare workers from 4 health facilities. Facilities in charge, care informants, we mean district health officers, epi officer, malaria officer, and chief medical officers. We included community elders, mainly midwives and community leaders. We also included community health workers and, of course, the parents and the caregivers, in total 32. This slide shows that the majority of the participants were female, both for qualitative and for the quantitative component. Allow me to speak about the results now. So malaria prevention and vaccination perceptions. According to the results, malaria was recognized by all participants as a burden disease. And this is not new, but it was important to hear from the participants. Caregivers were the ones who complained most about the many visits they have to do to health facilities due to the malaria symptoms. And some quotes are illustrative. It's just that I'm tired every day in the hospital, malaria, malaria, malaria. Also, the use of bed nets was the most known preventive measure, followed by garbage cleaning. And in fact, caregivers reported the use of bed nets for their babies. And this one said, malaria is caused by mosquito bites. It is necessary to put the baby inside the bed net. However, healthcare workers had some concerns regarding community misuse of mosquito bed nets. And they said, they sometimes use the bed nets to cover fields. They also use to spread peanuts. In terms of vaccination, 51.8% of the healthcare workers were aware that malaria in children could be prevented by tablets. Remember that this was a new intervention, and it was a pilot. We were about to introduce the pilot intervention in Mozambique, although WHO have recommended this last year. So they had experience, they had knowledge about malaria could be prevented with tablets, because this experience was coming from the SP intervention that is being implemented in Mozambique with pregnant women. 98.2% of healthcare workers agreed that use of bed nets are effective to prevent malaria. But here there are some challenges about the misuse of bed nets. And 99% of healthcare workers believed in mixed approaches, such as indoor spraying, garbage cleaning, effective use of mosquito bed net to prevent malaria. In terms of acceptability, from the caregivers' perspectives, results show that they're in favor to adhere to PMC. They were in favor to adhere to PMC for their children. They had good expectation on PMC intervention to prevent from recurrent malaria, to reduce the frustrating frequent visits to the healthcare facilities. And important is that they had trust in healthcare workers, healthcare, and in healthcare interventions that were going on. Much more interesting is that they believed in peer influence and they were willing to do active mobilization. So this caregiver said, I can talk to other mothers saying, let's go to the hospital. I can even take one of them to help me talk to other mothers too. So I take mothers from the community to the hospital to have this new medicine. From the healthcare workers, acceptability was also was shown to be also good. 69.6% believed that PMC would be effective measure. 92.9% believed that administering PMC during EPI sections would be easy and feasible. And they say, we see this age group appears with recurrent malaria. Yes, so the initiative is good. I think will reduce malaria. But they strongly recommended that good strategies for mobilization should be put in place. And they also recommended effective involvement of high-level district authorities, high-level care district stakeholders, local community, health community, and also training for healthcare workers to implement this intervention. And one of the healthcare workers said the mothers are much more concerned about the well-being of the children than themselves. So with a good explanation of the intervention, we will have good acceptance. The high-level district authorities should, he said, should be involved in this, so community can feel confident and adhere. Acceptability from community actors and key informants was also part of the results, and they believed in high community adherence, but they stressed the importance to improve communication between healthcare workers and community while considering different languages spoken in the district. Masinga is particularly, Mozambique in general has more than 11 local languages, and Masinga is also one of these provinces with many languages, local languages spoken. So key informants and community actors stressed the need to consider this communication, improve the communication, but also consider speaking different languages. They also stressed the need to massively and effectively disseminate message through the already existing local channels. And most interesting in this perspective is that they not only stressed the need for good community engagement, community strategies to mobilize the community, but also they highlighted the key message to deliver to the community. And one of the key messages was that the need to highlight that PMC does not replace other prevention methods. So one of them said, broadcast the intervention in the community meetings, in the places where there are funerals, churches, and anywhere where there are people. One key informant said, first, they talk about the drug, disadvantages, the good implications, then they will give these drugs. In terms of operational feasibility, can you remember that at the beginning we said that we also did questionnaires, direct administered questionnaires with head of facilities, and also conducted direct observation. So 75% of the healthcare workers here reported availability of sufficient materials to ensure healthcare for children. They also reported availability of in-facility sufficient team to ensure implementation of PMC. And they believed EPI was the right place to deliver and implement PMC. One said, I think it would be feasible because this target group, the first place where they come into contact is at the EPI. EPI stands for Enlarged Program of Immunization. It is even better. So they supported the fact that PMC was being implemented at EPI. Although it was feasible, according to this category of participants, there are some barriers that they stressed that we needed to consider. One of them was the water problem, because most of the health facilities they didn't have water, clean drinking water for the administration of SP. So one said, a clear example is that water problem is in many health units there is no water, and this also is regarding the water. And with our observation, we indeed confirmed some logistical barriers in some health facilities. We confirmed that there's some difficulties in accessing clean water in some of the facilities. We confirmed lack of spoons for administering the SP, and for some health facilities, there were no electricity, and some electricity suppliers were not working. In conclusion, PMC intervention in Masinga district was accepted to reduce the malaria burden and improve children's well-being. PMC intervention was perceived as relevant and operationally feasible, and integration to EPI did not show to pose huge changes to the health facility. So knowledge and practice of healthcare workers can be constantly shaped to adjust to new evidence to ensure better practice, and adapting the clinical intervention to the local context while engaging community members and stakeholders at all levels has shown to be paramount. So what we did after remember this is implementation research studies. After this study, and also remember that context plays a role in implementation research. So this specific pre-intervention implementation study was critical to access, capture, and comprehend the local perception of malaria prevention and the acceptability of PMC as a preventive measure. The results of this study informed the training contents for community mobilization activities few weeks before the start of the implementation. And I'm lucky and happy to say that we were fortunate to, after the study, work on the results and include the results and the key message in the training packages that were developed for the community mobilizer, but also for the implementers of the intervention, few weeks before that intervention. And when I stress few weeks, it's because that it's been shown with the literature that it's important to not have a huge gap between community engagement and intervention, because the community tend to forget about what was said. So intervention in Mozambique is taking part since last year, and midterm evaluation has been performed right now, and results are yet to come. Until from April to September 2023, more than 16,000 doses of SP were administered. So here, it is worth highlighting the importance of joint research collaboration between clinical researchers and social scientist researchers to produce insightful evidence from the local context and therefore deliver locally adapted clinical interventions. I would like to acknowledge the EDCTP travel grant. If it was not for this grant, I would not be here, standing here to present. So I'm really thankful. I know that there are many researchers who deserve this, but I was one of the luckiest, so I'm really grateful. I would like to thank EDCTP for the grant for the multi-pipe project, and I won't leave the stage without thank Masinga local district authorities, the participants, the field workers, and most importantly, Manyisa Health Research Center, IRD, Institute for Research and Development, and its global researchers and PIs, and all the consortium projects. This picture is in Masinga district, and this is the team of social, the pre-intervention researchers, and this picture was taken almost 6 p.m. in the night. We took the opportunity after a long field work and long visit to health facilities to see the sunset from the beach side. It was just 5 minutes, but for people when see the picture, they think that we were there in the beach, but we were coming from the field. Thank you so much for your attention.
Thanks so much for that great presentation. Do we have some questions? Any questions? I will ask a question then. Okay. So I think my question is linked to your last point in the next steps, where you were talking about clinical researchers and social scientists working better. I would like to find out your experience in integrating these two groups of researchers, and whether you are succeeding within your setting, or whether there are some specific challenges.
Okay, thank you so much for your question. First, I would like to say that it's really grateful to have this kind of collaboration with clinical researchers. But of course, there are many challenges, and one of the challenge that I'm aware right now is that most of the time when clinical researchers are designing the research study, they forget about social scientists, and they forget that the participants they are working, they intend to work with, they are human beings. They have social contextual, they have social culture, they have some contextual issues, their perceptions, they have their own views about their their own health, and they forget the clinical researchers to call on us or to collaborate from the beginning. And most of the times they tend to call us when the study is already there and the funds are distributed, and we end up having constraints about funding for the social science component. This is one of the challenges. The other challenge is when it comes to qualitative studies, and as you may know, after the interviews, in-depth interviews, we have to translate. Sometimes we have to translate, and sometimes we have to transcribe, and sometimes we have to translate. Imagine in Masinga district, we had local language, then we had to translate to Portuguese, and then translate to English, and this takes money. This requires funding, and most of the times the funds are not sufficient for this kind of activities. This is one of the challenges. So most of the times we solve this with good communication, a good explanation of what is need to be done, and sometimes we are forced to reduce the sample or reduce the techniques or the tools to perform the social study. Yeah, I think these are some of the challenges that I remember now. But in general, I'm glad that for the sake of the participants and the health, global health, public health, that the joint research with clinical and social science researchers is been shown that it is very important to come up with results that benefit the participants and they are locally adaptable. Yes.
Thanks so much. Just checking if anyone has a question. Okay, thank you so much.
Thank you.
Our next presenter is EDCTP Fellow and the only male in this session, Dr. Joseph Matuvu from the Makerere University School of Public Health in Uganda. Thank you.
Thank you very much for introducing me as the only male. Kudos to the males in this room. So I'll be talking about HIV self-testing in the fishing communities. As you know, fishing communities tend to be located in far-off places, usually in the lake and along the shores of water bodies. Sometimes, because they are far away from main services, they tend not to use facility-based services, so you have to look for them. So our intervention was a peer-led HIV self-testing intervention, which involved identifying men in the community, training them, and working with them to deliver HIV self-testing services to fellow men in the fishing communities. I have a team, as you can see. We worked with the Ministry of Health and several other colleagues, but I'm leading the presentation. So why did we focus on fishing communities? Fishing communities have high HIV incidence and prevalence than the mainland communities, and several studies have illustrated that fishing communities tend to be net sinks for HIV rather than sources of new infections. So if you look at the illustrations on the right, I think it's your right, you will be able to see that there are several lines getting into the fishing communities than those that are getting out. This was a study by Rattiman presented at AIDS 2018, and it was an oral presentation. So because they are net sinks, so they become up as high prevalent communities. But yet, men in these fishing communities tend to engage in high-risk behavior because they have money at hand, and this money pushes them to engage in risk behavior. Actually, fishing communities, men in the fishing communities can be classified as mobile men with money. They come from the waters, sell the fish, and then they can use the money in any way they want, and they go back to the lake the next day. So that's what pushes them to engage in behavior. So our primary objective was to determine HIV self-testing uptake among men into fishing communities following a peer-led HIV self-testing intervention, and then ascertained a proportion of newly diagnosed men who could be linked to HIV care. And our second objective was to assess linkage to HIV care after self-testing. So how did we do this intervention? The intervention was conducted in 2 fishing communities. The fishing communities are located within Lake Victoria in Uganda, and that's the map of Uganda, and the red circle indicates the lake. It's a lake which is shared by Tanzania, by Kenya, and then also Uganda, but we're on the Ugandan side. And the intervention focused on the islands in the lake called the Kalangala. That's a district, several islands, about 84 islands, and one of them is the one where we focused. And then we also focused on another island called the Buvuma, which is far away from Kalangala. So there were 2 adjacent fishing sites. These districts were selected because they have very high HIV prevalence, which is higher than the national average. Average HIV prevalence in these districts stands about 10% compared to 5.5%, which is the national average. So in each district, 1 fishing community was identified, working closely with the local leadership in the area, and then we targeted all the men in those fishing communities. So this was a social network-based intervention. Social network, as we identified groups of social groupings within the communities where men usually meet. They either meet as fishermen, they either meet as net repairers, boat pushers. There are several groups in the fishing communities. The reason we targeted networks is because network people tend to know each other. If you belong to a network, you know almost all the members in that network. If you belong to a WhatsApp group, you know the members in that WhatsApp group. So we targeted the groups, and then we identified 1 man from the group who would now be trained as their peer leader. So all are peers, but the trained one is a peer leader. So, and that's how the intervention was developed and delivered. And then the peer leaders were trained in how to distribute HIV self-test kits. They were trained in how to read the results and interpret them, and trained in basic counseling skills so that they can support their fellow men. These are local men who engage in fishing, men who are motorcycle riders in the fishing communities. So in a way, they are not your educated physicians. They are people, local people in the communities. So we asked each trained man to identify 20 members from within their group. So identify those people you know, refer them to the study team for screening. And during screening, we identified only those who were aged 15 years and above, who had HIV negative status or had unknown status, last tested for more than 3 months, and they were known as a member in your network. So we would cross-check. So you say you come from Joseph's network. Do you know Joseph very well? So we would ask you a few questions to verify that you actually belong to the network from which you are claiming to belong. And then you should have intended to stay in the community for 12 or more months because we wanted to do follow-up visits across time. So we did cross-check. People can belong to different networks. All of you here can belong to different WhatsApp groups. So we had to check to be sure we only enroll unique individuals, because if we identified you and you also belong to another group, then you would end up getting kits multiple times, and that would be difficult to follow up. So the eligible men were identified a baseline questionnaire, and they were requested to go to their peer leader to pick 2 kits, 1 for themselves and 1 for any other person in their social life. So what were these men that we enrolled? Most of the men we enrolled were aged between 35 to 34, basically had a primary level of education. This is usually the common one in our country. Most people are educated up to primary level. Very few really go beyond primary. About 32% would belong to the other group, but 62%, about 60 to 65% are usually around primary level of education. In terms of occupation, majority were engaged in fishing or fishing-related activities, but also had those engaged in business and other commercial activities. And 82% of the men had ever tested, but tested at least 3 or more months from the point of enrollment. So this is a fishing community. Mobility is a problem in these communities. 51% of the men reported that had moved outside their community at least once in the past 6 months. So this is the reason we targeted the social networks, because the members in the network would know each other's movements and would be able to target them and deliver the HIV self-test kits. And now the kits were given to the peer leaders, and the peer leaders had to give through their social network members. So 800 kits were delivered to the peer leaders, and then of these 782, representing 97.7%, were given out from peer leader to a member within your network. So in a way, it is possible to work through locally identified men to channel kits to the members within that network without waiting for them at the health facility, because they will not come. So of the men that were enrolled at baseline, 400 men enrolled at baseline, 90% were followed up at the first follow-up visit. Why 90%? Where did the other 10% go? I already told you the reason. They are always moving. So by the time we came back, we couldn't trace the remaining 10%. Now, the remaining 10%. Of those that we were able to trace and interview, 98% reported that they received at least one kit from their peer leaders. The intention was to give 2 kits, but some peer leaders decided to play games. They would say, I would look at my social network member and say, this one doesn't have a partner. Why do I give them 2 kits? So they would give one. What did they do with the second kit? That is a story for another day. Okay, so in terms of uptake, of the men that received the kits, we said 355 men, representing 98%, got the kits, at least from the follow-up interview. And then when we interviewed them, 99% reported they actually used the kit. We had a condition. When you use the kit, you had to return it to us for rereading. We wanted to be sure what you read on the kit is exactly what was appearing on the kit. And we had a high level of correlation, inter-reader correlation, because almost all the kits that we looked at, the results they had were similar to the results we saw, but there were some 5 to 10 men who read the results as negative, and our team read the results as positive, and then I'll tell you what happened to those ones. So 96% of those who self-tested actually returned the used kit to the team for rereading. So this is the proportion of men who had positive results. At the end of the day, we identified 14.5% of the men who came back with the results, with their kits, were HIV positive. Of these, 31% were newly diagnosed. So our intervention was able to identify 31% of these men who would not have known they were positive if they had not enrolled into the intervention. So, and then if you look at positivity by occupation, you see that the occupation-wise, fishing, those who are engaged in fishing and those who are engaged in fishing-related activities, such as net repairing, boat pushing, all of those categories that rotate around fish were most likely to be HIV positive compared to the other groups. And of those who are HIV positive, we according to the guidelines for HIV self-testing, when somebody tests positive, they have to go for confirmatory HIV testing, because this is just a screening kit. You just screen and then refer to the testing under national testing algorithm. So of those that tested positive and were first-time positive testers, that were 16 of them. Those who went for confirmatory testing were 87.5. So you had 14 of 16 actually confirming their results. But the number of men with confirmed HIV positive results was half of the number that went. So what happened to the other half? The other half included the people who read their results as negative, but our team read the results as positive. So they had to go for confirmatory testing, and luckily, in quotes, they turned out negative. So linkage to care was high, 71% were linked to care, but slightly below the expected global target of 95%. Of the men who had initiated care but dropped out, One out-migrated, and then the other one defaulted on their treatment. So in other words, we had 7 people who, actually I think 8 people who enrolled into care, and then, confirmed positive. 5 were initiated in care, and then 3 of these were still in care at the 12 months follow-up visit. So this was a pilot study, small study. That's why you see the numbers getting smaller. We just wanted to see, is it really feasible to implement this kind of intervention in a fishing community setting? And then we would apply for funding from EDCTP 3 to now expand the, to now try out the intervention in other fishing communities. So in conclusion, our peer-led HIV self-testing intervention resulted in near universal uptake of HIV testing, 99% tested with the kits, but linkage to care was 71%, which is slightly below the expected 95% universal target. Now, this calls for interventions, more interventions. And I think by interventions, dear colleagues from EDCTP, I mean money. We need money to focus on men and then try out innovative approaches to improve linkage to care, but also retention in care in other remote fishing communities. So, and then we also need innovative approaches to improve linkage to confirmatory testing, because not everyone who was positive actually went for confirmatory testing, and then we'll see how to link them to care, especially in those remote islands where they do their work. So I would like to acknowledge the support from EDCTP2, which is ending in a year or 2 from now as we move into EDCTP3. And I would like to acknowledge the Ministry of Health Uganda. The kits we used were given to us in kind by the Ministry of Health. I would like to acknowledge Bustema University, where I work. Some colleagues from Bustema could be here. We had a presentation, yes, there's one there, and another one there. We had a presentation in the morning about capacity building from the same university, so we're actually working. And then I would like to acknowledge the districts where we worked. Finally, that illustration, the graphical illustration, is important for this session. This session is community engagement. The World AIDS Day theme for this year, 2023, is let communities lead. So we actually doing work in relation to, we are ahead of time, in other words. Thank you very much.
Thank you very much for that interesting fisherman's perspective.
But I'm not a fisherman.
No, you are giving us an interesting perspective from working with them. Do we have any questions? I think you had a very nice presentation. So I see lots of hands popping up. See 1, 2, 3. So we'll do these 2 and then we'll come to my right-hand side.
Yeah, thank you so much. My name is Idal Koki from the Busara Center of Behavioral Economics, and I think I really like the work that you presented, and I have a question. So with regards to the intervention that you implemented, how did you come up with this intervention? Did you involve the community beforehand? Because I'm thinking in terms of social desirability of a group setting or somebody else giving me a testing kit. Some people would want to hide the fact that they may be HIV positive, and this might even discourage usage. But I'm just curious to understand how you came up with this intervention and ways in which we can explore involving the community even beforehand, just to co-create with them and understand what do they suggest as the best way to improve uptake of this product. Thank you.
Thank you very much. How did we come up with this intervention? I have 2 different answers. The first answer is those people advertised, and we saw the advert, and we said we had to apply and think through what is it that can get us money. On the other side, the intervention was developed along with the community. Initially, before the intervention was implemented, we're actually writing, I think I have a submitted paper. It will be coming out soon and we'll be sharing it out. How did we develop this intervention? It involved the formative research as the first stage. We engaged the communities and did research to understand how best can we reach
fishing community settings? Is it possible to get to the men? And if we have to get them, how do we do it? So we had focus group discussions with different categories of men in the different fishing communities. And this was building on our previous work. If you look for, there's a paper, Matov et al., 2021, if you search for it and add fishing communities, you will see that there is work we had done previously in another fishing community. So we are building on our experiences, but we did not use that experience alone. We said, okay, we know what fish these guys may call for, but still, since these are new fishing communities, let's engage them through formative research. So it started with community entry meetings, engaging with the key stakeholders in the community. From community entry meetings, then we had the focus in the formative research. We analyzed the results and looked at what people were saying. And most people were like, oh, if there is a way you can reach us in the fishing communities, that would be the best. We said, fine, that could be the line we are looking for, if you get what I'm saying. So we developed the intervention around what community members were suggesting, and we allowed for adjustments. We allowed for adjustments from the way we had thought about it to the way they wanted it done. Initially, they wanted to compare whether we would use two different approaches to select men, but then when we reached the communities, it was a different story. People were saying, no, we can line up, we can choose our person, we can do this, we can do the other. In one instance, there was a community volunteer who mobilized the whole village and promised them that if they selected him as the peer leader, each person would get 15,000 Uganda shillings. That's about $5. So we came to a group where everybody was there, and we said, so why are you here? That we have come to select our peer leader. But the voices were like, oh, they are going to give us money. So so we went through all those circumstances until we developed the intervention and then delivered it. So we worked closely with the communities, even in selecting. The community selected their own peer leaders. At some point, you would hear voices that person wasn't the one who would have been selected. But we said, you know what? You guys met and selected your own person. So to answer your question, and I've been answering anyway, we involved the community.
Thank you very much for this insightful presentation and findings. I'm Mohamed Afolabi from London School of Hygiene and Tropical Medicine. I wonder why you focus only on men in the fishing community. We know that men do engage in fishing, but there are other fishing activities or fishing-related activities that involve women. And I don't think you should do this kind of innovative initiative and leaving women out. I want to ask, in your future plan, do you plan to include the female population? Because I believe in the fishing communities, there are also women, and it takes two to tango.
Thank you very much. The name sounds familiar with the name I met somewhere in Kenya in 2011, 2012. Maybe you could be the one. We will talk. But in terms of the answer, yes, we have plans to do an intervention for women. Dear colleagues from EDCTP, we want to do PEST for women. This study was codenamed PEST for men, peer-led self-testing intervention for men. But all along, wherever I have given this kind of presentation, there has been a call for targeting girls and targeting women. So we are cooking PEST for girls and a PEST for women. So we will be at your doorstep to get the funding. But why did we go for men? Men are the blind spot in the HIV prevention response. Those who are in HIV programming will already know that phrase. Men are less likely to test. If they test late. If they link to care, they get lost to care very early in time and die more frequently than women enrolled in care. So men are a vulnerable group, although they tend to think they are a stronger.
Okay, so we had a hand here, and I had accepted this question. So if we can please pass the microphone to the gentleman on this side. So if you can keep your question brief, we've got one more presentation. There's a microphone here as well.
Okay, thank you very much for the presentation. I'm Abdulhamid Watunde from Nigeria. So I work on a similar project in Nigeria using digital technology for promoting HIV self-testing among young people. So I want to ask 2 questions. The first one is who coordinated the pre and post counseling for the testing, since it's a peer intervention? And then the other one is about the sustainability. Would they be paying for the kit? Because the kits cost about $2 to $5. So for sustainability, would they keep getting it for free? Thank you, sir.
Okay, thank you. Pre and post testing, how did we do it? We did it in different ways. The first way was to provide the people information. We had information leaflets, and then we told them if they had any questions, where they really needed a question before they tested, my number was there and other investigators' numbers. Number 2, we also provided, we were working closely with the nearest health facilities, nearest, not as near as next door, but at least they could call. There was a number they would call to call the liaison nurse that we were working with to get information. So for self-testing, largely, the issue is more about information, pre-testing information instead of pre-test counseling, because you want the person to do it on their own, but they can get as much information as they want before they do the test. If they feel confident to test, then they go ahead and test. If they still have fears, they can still keep on calling. The third way and last most important way was to train the peer leader with some basic HIV information so that they can answer a few of the questions that their social network members had. The last question was on sustainability. I thanked the Ministry of Health for giving us a free donation of HIV self-test kits, because the government of Uganda has a program for HIV self-testing throughout the country, and HIV self-test kits are available at almost all the health facilities. So, since we're working closely with the health facilities, I think it's possible, because they normally do outreach sessions to those fishing communities. They can always deliver the kits free of charge. Thank you very much.
Right. We had one hand up. You can ask your question quickly.
So I just, for the colleagues, I think it was from Kenya who asked a question, which was really good, so thank you. I just thought, from the research that you're doing, which is fantastic, I mean, could you extrapolate some of that work and actually do a multinational study? Because you are quite close, country-wise, to other fishing communities.
Okay. And the good thing is, with EDCTP3, we are working...
You know where I'm going. No,
we are working in networks. So, my Kenyan colleague, can you please, we can meet after this talk, and then we see how it works out. Thank you very much.
And then maybe giving you more ideas. I think, no, but the reason I picked up on that, I think the part about the women and actually the young girls is very important. And I think one of the things working in the fishing community on the other side is the amount of period poverty with young girls, and then how quickly they get HIV infected. And this actually comes from different work. This comes from SHISTA work and you know, trying to identify who's, you know, is actually infected, and then we realized that was coming from. So 2 questions in one, you know, the point about the girls, I think, which was answered, which is great, and maybe whether you might be considering not just focusing on HIV, but on health in general for diagnostic of other conditions, perhaps, that are equally important.
Very good. I need to talk to you after this. Yeah, we need to create networks, so that's one way, and then we can build a network and apply for funding. Thank you.
Thank you very much.
Thank you. Let's invite our final speaker in the session to the podium, Dr. Rachel Hallett from the Good Clinical Trials Collaborative in the UK. Thank you.
Thank you. Do I need to move it on? Sorry, it's very calm. Thank you. You click it. Got my name. Thank you very much. Fantastic. Thank you. And thank you to the previous speakers as well for a fantastic session. So I'm representing here the Good Clinical Trials Collaborative. I've come from the UK. I'm going to talk now really about a community endeavour that's slightly different to the ones you've been hearing about. And this is a community approach to writing a set of guidance for good randomized controlled trials. So I'd like to just very briefly talk you through the rationale, the writing, the product, as it were, of this endeavour, and hopefully encourage some of you to come and speak with us at the stands that we have here and learn more. Okay, I'm sorry, this one. No, this here. Thank you. Got it. So let's just start. And then we're here. Thank you, sorry. So the initiative began with our scientific lead, Professor Sir Martin Landray, who's a cardiologist by background and an experienced clinical trialist over many years. And it really sort of originated from that reflections and frustrations that there's such a paucity of evidence-based, strong evidence base for a large number of clinical decisions, and that the reliable evidence from RCTs just isn't there in so many cases, and that's because either relevant trials haven't been performed at all, or because they've been performed but were inadequate in some way. And of course we know this it can harm individual patients and public health when we're lacking data to make informed decisions. And some of these sort of contributions to the rationale really and to the problem, and I'm sure this isn't news to many of you here, and that clinical trials over recent decades have escalated in cost. Thinking about new pharmacological treatments now, $1 billion price tag is not unusual. Contract research organisations and the sort of genesis and the rise of these in performing clinical trials really contribute to these spiralling costs. And we know that many trials that do run are not going to produce reliable evidence, and that's because generally through to poor design, poor ability to produce enough numbers or to recruit enough patients. And this was really thrown into sharp relief during the COVID pandemic. And this important analysis that has been raised by at least one of the speakers this week, shown by Boogan and Woodcock in a review of COVID treatment trials, that only around 5% of the collated trial arms, when they analysed them, were adequately randomised and powered and had any hope of producing a reliable result that people could change policy and practice using. And of course this isn't just happening during COVID. This is something that we see across many disease areas. We also see that the pharma industry has generally moved away from common diseases, from producing evidence about moderate treatment effects that are nonetheless clinically relevant and relevant to patients, and have moved away to looking at more lucrative blockbuster drugs, particularly in the fields of oncology and more targeted medicine. And of course that means that the proportion of people who are benefiting from RCT results is dropping. And perhaps relevance here, thinking about trials that are never done, and the numbers of RCTs in other health interventions, not just pharmacological, that can produce really important evidence base are simply not done, and there's a whole variety of reasons for that, but cost and complexity are two of them. So we can see that clinical trials are not maximising their potential. And of course this isn't, we're not the only initiative to recognise the challenge. We've heard about pandemic preparedness. This is one of those initiatives, a report on the 100 days mission from the UK government to the G7 nations. And of course we've heard about the Panther initiative whilst we've been here earlier this week. Really focusing on the fact that if we don't have a good clinical trial system in place in normal terms, normal times, quote, we don't have any sort of hope of being prepared for the next pandemic. The World Health Organization response to the WHA resolution that was passed last year is something that was really considered very nicely by Dr. Vasimorthy yesterday in that session. So if you didn't attend that session, I'd really recommend you catching up with that on the recording. And he laid out the response to the resolution there to strengthen the clinical trial infrastructure and ecosystem. Another initiative in the States has been working in this field for more than 15 years now, and this is just a small sample So of course, the challenges are recognised by many people, and not least their work by EDCTP in terms of trying to drive impact through reliable clinical trials. So how can we start to address some of these challenges? The Good Clinical Trials Collaborative was convened to think about producing guidance. And good guidance can help by focusing attention on all of these issues and thinking through in a collaborative way what are distilling the key elements of what a good clinical trial really is, and supporting people who are running them, funding them, regulating them, and so on. But thinking about what good guidance actually means is sort of the first step of that. What do we mean by good guidance? And there are elements that come out of that. Firstly, and importantly, that it's focused on good science and ethics, and stripping back some of the detail, thinking about what is it that actually materially influences both the well-being of the trial participants and their safety and the reliability of the results. And elements that influence those two aspects, of course, are really key to focusing on producing good trial results. It has to be clear and concise, it has to be understandable, and this allows flexibility in its interpretation. So making it accessible and understandable means that people involved in running clinical trials can then think critically about how they apply the principles to their own setting and context. And I've heard that as a theme running through this session and many others, that context matters very much. Of course, it has to be inclusively developed and capturing all of the viewpoints, all of the constraints and barriers of all the different people involved, not just the researchers, but everyone across the whole run of a clinical trial, essentially, and very much including the patients and the public in that. And it has to be progressive and durable. So we're not thinking about guidance that's valid now, but thinking to the future, thinking about the types of technologies that are coming forwards, the types of health challenges that will change. We're thinking about guidance that sits above that and is relevant for all the types of trials we might want to run now and in the future. So just a little bit about the writing process then. So the collaborative came together, the writing group came together in 2020. It drew on expertise and experiences of an inclusive and a diverse role type of people, and that's just sort of give a flavour there in the chart of the breakdown of the contributors by role type. So they are involved in clinical trials across the whole sort of run, the whole gamut. We have a similarly diverse steering group who advise on the writing and the iterations of the guidance. So as you would expect, it went through several rounds of consultation, writing, reconsultation, redrafting, to make sure that everybody's views were captured and that it really was fit for purpose. It's now published since 2022, and so we have a website that it's downloadable from. Earlier drafts of the guidance have been translated, and we're working now on translating the final version into several languages. And this is just to give you an indication of during the public consultation phase, we received a number of written responses from individuals, from organisations, and to give you an idea about where they came from in the world. So the final guidance has been arranged under 5 key principle headings, and I've listed them there to give you an idea of the detail below them, but I'm not going to go through those. Obviously, we'd very much welcome your input and feedback and coming to talk to us. We have some printed copies of the guidance if you'd like to come and take them away from our stand here. So they come under the topics thinking very much about design, and that good trials produce a scientifically sound answer to a relevant question. Thinking about ethics, that good trials respect the rights and well-being of participants, that they are collaborative and transparent, that they're designed to be appropriate for their context, and that they're managed, the quality is managed effectively and efficiently. And so although this was seen to be the best way to divide up the principles here, of course, we want to sort of emphasise that it's a holistic document. It's to be considered in its entirety, and there are many, many strands and threads that sort of link these principles together. Then it's not a pick and choose the list, and so the guidance is seen, as a whole. Really, perhaps just to emphasise a couple of other aspects of it, just to make the points that the principles are written in such a way that they talk about a key message under each of those headings, and they talk about why they're important, and that really supports people to use them as a decision-making tool in their own contexts, understanding why each of those is important. They recognise that many trials pose little or no additional risk to participants compared to normal clinical practice. And of course, that's not always the case, but it's really important when thinking about a proportionate response in terms of management, in terms of oversight, in terms of thinking about risk, and that taking that into consideration is really key. It allows the trialists to determine efficient and effective solutions in their own setting and context. And it discourages excessive or defensive practices. So the reduction of waste and thinking about streamlining and efficiencies is another one of those threads that runs through the guidance, noting that increasing your documentation is not the same as increasing your quality. So just to give you a little flavour now to end with of the activities that now as a secretariat we're involved in. It's really about promoting the guidance, about talking to people who are likely to use the guidance. And so we're having conversations with all of the key stakeholders that we want to think about ways in which they can take up the guidance. Just a couple of things to note that have been on the agenda very recently. The revision of ICH E6, or Renovation 3, of the Good Clinical Practice Guidelines. We've been very involved there in producing a detailed response to that public consultation, of course emphasising where we feel it aligns with the principles and saying how important it is that they are maintained within the final document there. And I'm sure many of you have had that on your radar as well. And similarly, this was also mentioned by Dr. Basimorthy yesterday. We're really encouraged in terms of discussions with WHO that in their scoping process to look at what guidance was available as they respond to the WHO resolution. They found the value and the applicability within the Good Clinical Trials Collaborative Guidance and have adopted it as a source document within their own recent released guidance for best practices for clinical trials. And that was open for consultation until September. So the Collaboratives guidance now forms essentially Section A of the WHO new best practices for clinical trials, and of course we hope that remains the case in the final version. Other activities that we're really keen to partner with people on are thinking about bringing it to bear in practice, thinking about bringing it from its sort of overarching, fairly high level, the way it's been written, into practice on the ground, in the field, in real life, and to think about how we can look for people to show examples of that. And we've heard some fantastic examples already today in this session. Of thinking about context-specific decisions, of thinking about engaging with your community and working collaboratively with partners, throughout the whole course of a study. And we're recognising here, of course, that the impact from this currently, PDF or document is only going to be seen when the guidance itself becomes embedded into people's practices and policies and into their everyday workflows. So one other initiative I'd just like to highlight here is one of these partnering activities that we're really excited about, and it's a new grant that we've received from Wellcome to partner with other very experienced clinical research networks and to sort of draw on their expertise, thinking now about moving that towards bringing the guidance into practice. So we're learning from them about the specific challenges within their areas. And I hope they don't mind, the partners who are here, that I've put the picture up because this is the first meeting where we've all been in the same room together. So it's been a very exciting meeting for that reason as well. So I hope in future meetings we'll be able to talk to you about the results of this project. So we're calling this project PRISM. So just leave it to say then, really. We would love to see any more of you. We've had some great conversations here. Do come and drop by the stands that we have here. Come and have a look at the guidance. It would be fantastic to speak to any of you who can see some direct relevance here or want to think about how this can influence practice in your area. We've got the website there. You're very welcome to sign up for our mailing list as well. Come and grab a copy of the guidance and have a chat with us. That would be great. Thank you.
Thank you so much for your presentation. Do we have any questions? Please go ahead.
Yeah, thank you very much. Very exciting initiative. I was particularly fascinated by the fact that over the past 2 to 3 decades, we have seen so many guidelines from ICH, from WHO, from regulatory authorities, and so on. But yet, those guidelines have not actually helped to improve on the issue, on the question of trials ending informatively. So, is there any degree of certainty or assurance that you can give principal investigators that if they follow these guidelines, the trials are likely going to end up informatively, or informatively, they will not represent waste of resources, time, and effort?
Yeah, that's a great question, and you're quite right to say, of course, people are following multiple sets of guidelines, and yet it is not preventing a lot of these issues. I can't say 100% with certainty. All I can say is that the large number of people who've contributed their experience to writing, to reviewing, to pulling it apart, to thinking about the guidance and what it means within practice, I think really just reflects the fact that it's a very big community that's written this. It's not just the small secretariat here, and they have considered very strongly what the problems are, what the rationale is for doing this, where the problems lie in generating this guidance, and allowing people to make decisions, I think, is a key part of that. So it's discouraging people from taking a very defensive view of running a trial and making sure they comply with all elements, and it's getting people to think very constructively about what works in a particular context, which involves the people, involves the infrastructure, involves the stakeholders there, and applying the principles in that way with a critical thought, I think is much more likely to lead to success than the current guidelines.
Thank you so much. So I think we've come to the end of our session, a very productive session. And I think community engagement is extremely important. We have so many products in the pipeline, many that are coming to our communities. So there will be an increasing demand on our communities to continue taking part in clinical trials and clinical research. So I will check with Nuran if you have any concluding remarks. Okay, she says no. So thank you everyone for joining the session, and again a round of applause to all our presenters.